Okay, hello everyone registered. Good evening. I hope you've all had a good day at work. Have you all got a cup of coffee? We've got about an hour and a half that we can go for. I'm hoping that you all send lots of questions so that we can answer pretty much any question you want to ask at any time. There's a button apparently at the bottom, so you just click, write in your question. There's a little bit of time lag, so just be patient, and then we'll get around to your question, okay? I've got some slides that I've prepared just to start us off while we are waiting for your questions to come through. And our topic today is surgical extractions for the general dentist. I'll go through some cases. We hope to field some questions from you guys. And towards the end, I've got some CT scans to show you because I've had a few requests on how to read CT scans. And I've brought my computer along, so I will also show you how I read my CT scans on my software. So, surgical extraction challenges. Endodontically treated teeth, as you know, are challenging. Sclerosed teeth, for example, in elderly people. Dense bone, so older male patients, older patients. Teeth with compromised tooth structure. Large neighbouring restorations. There's the risk of OAF, which a lot of people are wary of, which is rightly so. Limited mouth opening and access. So these are all the challenges that we face when we're doing surgical extractions as a general dentist in our daily practice. Okay, so this patient has presented to me a couple of months ago. The general dentist had removed the 1-4. She really struggled with that because it used to be a bridge. The bridge was then sectioned, as you can see, and the dentist referred the 1-6 tooth for me to extract. So this is the kind of tooth which is completely within the scope of general dentistry and definitely a tricky one to remove. The reason being A, is root canal treated, as you can see. B, quite a big crown. So how we would approach that, how I would approach that would be to firstly just section or remove the crown. I have had students ask me, oh, would you section the crown off, etc. That will take you many hours. So my answer is no, just horizontal cut and take the crown off, and therefore you're going to have the roots. Now we've got a question come in from Hasita Pelinda. What's the best way to go about extracting a tooth with bulbous roots? And so I'll answer that one first, okay? So if, for example, let's pretend this case had bulbous roots, okay, as well as root canal treated teeth. So if we go back to the slide so you can see. So for example, if that tooth had a bulbous root and it was root canal treated, so that would really make your day, okay? So let's just pretend like that, okay? So how I would approach that would be, the first thing I'd do would take the crown off, okay? Once you've taken the crown off, you've basically got 2 or 3, in this case 3 roots to deal with. When they're bulbous, you've actually got to remove more bone to remove the tooth. Now these roots are fairly straight, so that actually makes it quite straightforward. You basically just need to remove more interseptal bone on both sides, more than the undercut of the bulbous root. So if you manage to drill all the way down interseptal and mesial and distal, then you're actually creating space for you to remove that bulbous root out. So what happens a lot of the time where people go wrong is you've got the tooth root fairly loose and you're thinking, oh, it's almost loose, I'm almost there, okay? And you've put a little bit too much force, and what's going to happen is that it's going to fracture there, okay? So when you know and you notice that it's bulbous, do not be fooled by movement of your root, because the root will be very mobile, but it just won't come out. And that's when you know alarm bells should ring. This is a bulbous root. Don't keep luxating because you'll fracture the bulbous root. You should keep drilling, remove interseptal bone, try and preserve the buccal bone, yeah? And then if you remove enough interseptal bone, and in this case there's plenty of room mesial, so I would go mesial, I would be wary not to go too much distal, then you're actually going to remove the undercut that's holding your bulbous root in place. And that root will then be easy to take out. It's very, very tricky if you fractured that bulbous root to take that root out. You've got the sinus here to contend with. It's difficult to see. It's an upper, so I just keep in the back of your mind, if you have a bulbous root, don't be fooled if the root is very, very, very mobile. Still keep drilling, especially around the end, just to get that bone undercut out of the way, and then you'll be able to take that tooth root out. So basically it's working root by root, trying to get the undercut of the bone away from interseptal and from mesial, and then that will allow a path of exit for your tooth. So this is that case that we talked about before. And I hope that answers your question. Send me another question if I haven't answered it enough. This is a fairly straightforward surgical extraction. So how I would approach this, I actually wouldn't necessarily raise a flap. I would just go straight for sectioning, and I would start sectioning from the furcation upwards, okay? And after you section, in some cases, you put a luxator down in the middle, and it may still not have enough mobility for you to remove the roots. The reason is that it's root canal treated, and there's hardly any periodontal ligament. So you don't have very much periodontal ligament in there. Therefore, in these kind of cases, you have to drill. So we've got a question from Paul Birch. What sort of burr is the best for bone removal? I use a straight handpiece. So in my straight handpiece, I've got a burr that is tungsten carbide, and it has this kind of shape here, okay? It's about, say, from memory, about 1 centimetre, maybe 1.5 centimetre long. So that is the best burr to go around retained roots. If I'm doing wisdom teeth, I use a number 2 round burr, okay? Because that round burr will reduce the that's not funny, there you go. The round burr will reduce the buccal bone, but for bone removal around roots, then I would use a straight handpiece or a contra angle with a tungsten carbide oral surgical burr and this kind of narrow shape. I don't like the tapered ones so much. There are tapered ones, but I like the flat ones. That's just personal preference. But if, for example, in this case, if you can imagine having that straight round burr, just basically whiz around mesial and distal, you'd get rid of all the bone that's holding that tooth in place just from pretty much running your burr, a little bit mesial, a little bit distal, and a little bit interseptal. And you're basically creating room. Once you've done that, you should be able to get those 2 roots out, even with a little bit of a curvature, okay? So we had an X-ray sent in from Dr. Shepherd, so thank you for sending your X-ray through. Her question was, how would I approach the extraction of the 2-7 tooth? So it's a really good question. Thank you for sending it. And obviously we've got decay here that we can see on the 2-7 tooth. In terms of approach, before I even start surgery, I would definitely warn the patient about the risk of an oral antral fistula. So as you can see, we've got fistula here, or your sinus here, so there's quite a high risk for oral antral fistula. I'd also warn the patient that there is a risk of a fractured root. Where would the root most likely fracture? Pretty much there. Okay, and so that's the reason being that angulation of the root is quite difficult to remove, especially if it's more elderly or a male patient, then the bone is quite dense, so you may not be able to retrieve that whole root. So I'd warn them just in case, because if that fractures, I generally will not go in to try and find that root because it's just too dangerous. You're going to end up pushing that up into the sinus and then causing complications. So if I was going to plan to remove that tooth, I would actually section. So I would pretty much take the crown off. Take the crown off so that you're down to this kind of level, so you don't have the crown to worry about. And then I would actually start sectioning from the furcation up, and I'll split the 4 roots separately. Okay, so for example, if you're looking at it from a occlusal point of view, there's going to be, it seems like there's two buccal roots and 2 palatal roots. So use your section buccal, section mesiodistal, section here as well. So basically you're dividing the tooth into the anatomy of the roots. This little root we're probably going to remove first. So you drill kind of mesial and interseptal mainly. Don't drill too much buccal. Try and create space. And what's going to happen as you're drilling, you're going to have enough space for one of these roots to come out, which then gives you enough room for this root to rotate out this way, okay? And then separately, this root will come this way and this root will come this way. So you can see the direction of the roots and the most likely path of exit, the hardest one being this one, of course, okay? So try and get the distal out first, and then attempt this mesiobuccal and try and get the whole tooth out. Also, if you have a curved root like this, if you remove this bone here interseptally, you're going to give it more room to come out. Also, if you remove a little bit of bone mesial, you have a luxation point, again for that tooth to come out. So I hope that answers your question in terms of how to remove this particular tooth, but the principles are basically the same, which is to section and remove interseptal bone, remove distal bone, and find the path of exit, okay, for each root separately. We had a question about trismus in infection. The question was by Raymond. Raymond's question was about his patients who had difficulty opening jaws, and later on he discovered that it resolved when he removed the wisdom tooth. Initially, he said he thought that this was because infection leads to pressure against the muscles of mastication and hence cannot open the jaws. However, he said some of these teeth show no PA radiolucency, and now he's just confused. Why would patients find difficulty opening the jaw when it's in relation to wisdom teeth? And then the second part of his question is it possible or common for upper and lower wisdoms to radiate pain to the temporalis and cause headaches? And if so, which teeth tend to do so more commonly? So Raymond, thank you very much for your question. So I've prepared a slide for you so that we can discuss anatomy a little bit more in depth. With the question about the periapical radiolucency, you can have a wisdom tooth infection, which is a soft tissue infection. If it's a soft tissue infection, for example, pericoronitis, then you're not going to be able to see much on the X-ray, especially in the early stages of the infection. So you could be having a patient having, say, pericoronitis. That pericoronitis is a soft tissue infection that you can't see, which is why you don't see a PA radiolucency. And definitely you're on the right track there. You can get infections from the mandible, come through and go between the fascial spaces between the ramus and the masseter. And therefore, if you have swelling or infection or edema in these areas, you're going to have trismus as it tracks through into between the mandible and the masseter. So in answer to your question, yes, it's possible that an infected wisdom tooth could cause trismus, and then I would give the patient some antibiotics, get that infection sorted out first, and then on the basis of their wisdom teeth, if there are symptoms and so forth, then remove the wisdom teeth. I'm not surprised that you end up having the patients, their trismus is treated after you remove their wisdom teeth. In terms of the other question about the, just go back to the question for me, Simon. The second question was, let's see, is it possible or common for upper and lower wisdom teeth to radiate pain? Right, so the wisdom teeth themselves would not directly cause the pain in terms of temporalis and cause headaches, but in my experience I've found that if patients have wisdom teeth pain, then they tend to grind at night, and if they grind at night, then that can lead to trismus and pain and TMD from basically overactive masseters from the pain of having infected wisdom tooth. So if that answers your question in a roundabout way, I hope. Question from Paul Birch. In the 2.7 case, so we'll go back to the 2.7 from Dr. Shepherd. Are luxators dangerous in that situation? Good question. So in this situation, I use quite fine luxators. There's no point using, so if this is a one-to-one picture, you have luxators that are about, say, 4 or 5 millimeters in diameter. That would be too large in this situation. Okay, that wouldn't be a helpful instrument. You need something maybe 2 or 3 very small luxator, very fine luxator. Why? Is because you're actually removing bone, and after you remove bone, you're going to put the luxator down and basically wedge it between the bone and the root to put enough pressure down here, for example, this is sectioned, right, to be able to rotate that root out. Luxators are, I think, people put a bad name for luxators because in university you're taught luxators are dangerous, don't touch them. It's really, really dangerous. Yes, it's dangerous if somehow you pushed the luxator straight through and pushed the root into the sinus, or you slipped and end up, hurting the patient in the palate or something like that. So an uncontrolled use of a luxator is definitely potentially dangerous. However, I don't use elevators at all. I only use luxators. So I think elevators are actually quite useless in terms of extraction technique. So in answer to your question, possibly luxators can be dangerous if you don't know how to use them, but luxators are just so useful in these situations. I don't see how you could even get an elevator into this kind of area, into this space, small enough to then rotate these roots out. You need a nice thin instrument that is about the same size and shape as the trench that you've drilled, so that you can luxate that root out. So I hope that answers your question. Keep them coming. Question from Lisa Holiday. Would you always raise a flap when you decoronate a tooth? Very good question, and my answer is no. I generally don't raise a flap when I decoronate a tooth. Why? Because I'm not actually touching the buccal side of the tooth. So I don't need access to the buccal. I don't need access to the buccal bone either. So generally speaking, if I'm decoronating a tooth, I just literally get a burr and cut it at the CEJ. Not all the way through. You can just cut it 2/3 of the way through and then get the larger one of the luxators, crack, take the crown off, and that's pretty much decoronation. You don't need to raise a flap for that. And then after that, you section, and again, when you're sectioning, you don't need to raise a flap for that either because you've got access. You only need to raise a flap when you don't have access. So for wisdom teeth, for unerupted teeth, then you need to raise a flap. Or if you're having difficulties with accessing, so for example, you started sectioning the teeth and then you can't see the mesial root of an upper molar, then if you struggle with that, then I would raise a flap so that you can see better. Okay. If they're having an implant, then you don't really want to remove buccal bone. However, if they're not having an implant and you really can't get that little tiny bit of retained root out and you want to, then I would remove buccal bone to access that small part of the retained root left. For example, if it was a hooked mesial root and I can't get to it, then you can sacrifice the buccal bone to get to that if they're not having an implant. If they are having an implant, please do not remove buccal bone. A question from Rohini B. Please discuss the best incision and flap designs for exposing mandibular third molars. Okay, thanks Rohini for your question. For that, we should have a look at some wisdom teeth cases, I think. So if I click to a soft tissue picture, sorry, just find one for you, Rohini. Like, for example, so if we, for example, have a look at this case study to answer your question, there are two flaps mainly for wisdom teeth. One is an envelope flap with a distal relieving incision, and the second is a trapezoidal flap, so three-sided flap. So when do I decide to do which? Basically, if I can be more conservative, I will. I would do an envelope flap for this case, so basically it goes this way. Sometimes you don't have to curve up the papilla, you can basically just go straight. Okay, and I would do a distal relieving incision. So your lingual nerve is somewhere around here or here. So your distal relieving incision will be round about 11 o'clock. If, say, for example, that's 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock, that's about 11 o'clock. That's where I would put your distal relieving incision. This first part is down to bone. And then when you come up past this mucogingival junction here, this is the buccinator is in here. So don't go too deep because the patient will have a lot of pain if you go too deep with this part of the incision. So this part of the incision of the distal incision is down to bone. This part here is in soft tissue, so just lightly. Don't cut too deep because underneath the muscles of the buccinator you cause the patient a lot of pain if you cut too deep there. So that would be my go-to flap. This would be an envelope flap, so round the tooth to the front and then a distal relieving incision. I would raise the flap from either this section, this area here, okay, and start opening the flap up backwards, or I would raise it from the distal and then bring that forwards. So either direction, but start somewhere along here or start somewhere here, okay? It's very difficult to start peeling a flap from where the tooth is. Now, just go back to here. If you had a really difficult wisdom tooth, then you might plan a little bit of a larger flap. So for example, sorry, go back there. You could do a distal relieving and then along the gingival margin and then a mesial relieving. Okay, and that would give you more room here. So let's have a look at the X-ray, for instance. These are fairly straightforward wisdom teeth, yeah? So you don't really need a very difficult, it's not difficult to remove, so I would basically just do the distal relieving that I showed you and then an envelope. That's it. And the same here, distal relieving and an envelope. However, if we find a case that's a bit more difficult, so if you go backwards a bit, bear with me. So like this case here. Oop. Okay, so in this particular situation, the teeth are unerupted. Okay, so I would actually, and I really need to get into this area here so that I can A, section the tooth, and B, remove and gutter buccal bone. So therefore, I'm going to make life easier for myself, and I would do a mesial relieving incision to give me plenty of access to get to this tooth, because I know it's a difficult tooth to remove. Then I would basically, sometimes I would come up the ridge a bit and then do my distal relieving. Sometimes I just basically do a triangle, okay? And that would open up that nicely. So the same in this situation, quite a difficult impaction. I need access to the mesial, so therefore I would do mesial relieving incision and then distal. Sorry, not really to proportion, but you get the picture. So similar situation here. For this particular, oh, I've got another question. Okay. Question from Sui He. That's okay. If that 2-7 curve root breaks and is left in situ, but the patient started having OAC symptoms like bleeding nose, what can be done? Do we go back in and try and remove that root and then buccal advancement flap? So that's a very good question. So we go back to the picture that we had here. Okay, good. Dr. Shepherd, everyone's interested in your case, which is great. So what happens if there is a fractured root and the patient has symptoms from, say, bleeding nose, so forth? I rarely see the bleeding nose, to be honest. Most of the time, if you cause an OAC, you can see an OAC. It's pretty obvious because you can see the soft tissue underlying. I would, for me, I feel comfortable to retrieve that root. I would definitely flap so I can get better access. And I use quite fine luxators to basically tweak the tooth out, either with root picks or fine luxators, removing some bone to be able to get around, for example, this area here, this area here. So if I remove enough bone, this tooth root basically is bouncing up and down on soft tissue. And then I'm able to just grab the root and take it out. But it's very, very difficult. So if you're not comfortable, the worst thing you can do is push too hard and pop that root in the sinus, because then you've actually got to do a Caldwell loop to get that retained root out. So you're better off leaving it be, even if it's fractured in there. And two options: number one, it gets infected, then you refer to your max fax to take that out, because they may end up having to do Caldwell loop to take that out. Or B, let that root just make its way down naturally. So it may make its way down and then you'll be able to access it when it's further down. I'd be wary, if you're a beginner at surgical extractions, about trying to fish that root, because it's very, very easy to just press too hard with your luxator. It's just soft tissue here. There's no resistance at all. If you push up, then basically the tooth root will pop in. How I do it is basically with very, very little upwards pressure. So I don't luxate up so that the root doesn't pop into the sinus. I make sure that I keep this whole root in one piece, right? If you keep the whole root in one piece, remove bone, mesial, distal. I've got plenty of tooth here to get a curved artery clip and grab onto that and pull that out, yeah? It would make life really difficult for myself if I happened to fracture it here, which would be worst case scenario, because you just have nothing to grab onto, okay? So make sure that you keep this whole root intact so that you've got something to hold on to. You don't want to be pushing up, because if you push up, you're going to push the root into the sinus, and that is a Caldwell loop procedure to get that root out, which is not in the scope of general dentistry. Make sure you remove enough bone, mesial and distal, to be able to give this root a good chance and a good path of exit. Luxate, but not too heavily. Just be careful, and mainly get like a curved artery clip and pull. Okay, that's most important. Do not push up, because that's when we get into tiger territory, pushing a root tip or fractured root tip up into the sinus area. I'd rather you leave that root tip than make it pop into the sinus, because you can't have an infected root in the sinus. It needs to come out. So then that's a referral, that's a GA, that's the patient going through, quite a major surgery to get a little root out for you. If it's left in there, sometimes what happens is that because of the cilia, that little root tip will end up going up to the ostium and blocking the ostium. So again, dangerous situation. So if you fracture a root and you pop it into the sinus, you cannot just leave it in there. That you need to refer and they need to seek treatment to get that root removed. However, if you fractured the root and you left it there and you gave them antibiotics, everything healed up, then on the contrary, that is actually safer. Just tell the patient, monitor them. If there is an issue, then you can refer them off to get that root removed. But it's not the end of the world if you fractured a small part of root in there. You prevent an OAF and just let it sit there. Some of the time, it will work its way down. Much safer that way. Hope that answers your question. Two questions from Sarah. What is my opinion on using endophiles to retrieve fractured roots? And from Paul Birch, what is going on with the upper molars on the next OPG that you showed? Okay, so we answer Sarah's question first. I've probably only tried using endophiles once. I found it just for interest, basically. I don't do it on a day-to-day basis, so I can't really tell you any particular techniques. But I guess if you get enough retention in your endophile to pull the root out, that's fine. But again, you have to be careful not to push up. So if you push up with a luxator or you push up with an endophile, it's not great. So just be careful with that. I hope that answers your question. Paul wanted to know about a upper molar tooth, I think, in one of the slides. I'm not sure which slide you're referring to, Paul, because there were a few scans that we were talking about. Is it this one here? So maybe, Paul, if you just write in which case you wanted to talk about. Yeah. So endophiles, back to that question, I don't use it routinely. I've tried it once just out of curiosity. I just prefer to use a small luxator and just kind of wiggle the root out and use like a curved artery clip to pull the tooth root out. But you can use a Benix extractor, or you can use endophile if that's something you can do. That's fine. Have we got any news from Paul about which X-ray he wanted to talk about? Not at the moment. Okay. Okay. Well, what we can do while we're waiting for Paul to reply is we can have a look at. Let's see. It's about 6:30. Slightly more complicated lower 8, so maybe Paul, was it one of these ones? Because there were two complicated 8s. This one? Yeah, this is interesting. So good question, Paul. This referral was for 4 wisdom teeth to be removed. So when the patient came to theatre, I looked at the case, and the 7s are actually buccal to the 8s. So I was in theatre, the referring dentist had said remove 8s. And I actually, in the middle of theatre, rang the referring dentist up and say, hello, the 8s are actually in line, and the 7 is actually more buccal than the 8. So I prefer to remove the 7 instead of the 8. So I ended up removing her 7s and leaving the 8s in, because one tooth, which was the 7s, were actually buccal to the 8s. So basically, for example, if I draw, we had the 7 was here, And the 8 was pretty much like this, and then the 6 was here, and the 5 was here, and 4 was here. So I just took out the 7 and left the 8 in there. So good spotting, Paul. That's the story with that OPG. Yeah, so I haven't seen that very commonly. It's like pretty much like a buccal impaction of the 7, or you can call it a palatal impaction of the 8. Yeah, thanks for spotting that. Question from Bei Chow. How do you minimize post-op pain after a difficult extraction? So I'll answer that question first, and we've got another one from Andrew. So in terms of minimizing post-op pain, if you are doing surgery and is taking you, say, half an hour, 45 minutes, maximum an hour, that's the best way to minimize post-op pain. If you've got your patient in there for 2 hours taking your tooth out, you're just creating too much trauma, like too much surgical trauma, and you are actually causing the post-op pain. So really looking at case selection, looking at what teeth are you're attempting to do is very important. Attempt a case that's within your kind of scope or within your comfort. Try not to go too difficult too soon. So if you're in there for 2 hours doing a surgery, you're more likely going to cause patient post-op pain. Whereas if someone can remove a tooth in half an hour, 45 minutes, then it's reasonable. Patient will have post-op pain for 1 or 2 days. I routinely give them antibiotics, so amoxicillin if they're not allergic. I give them Dex, so I give them 2 days of Dex, 4 milligrams BD if it's a very, very difficult impaction. And I give them Panadine Forte. Sometimes my sedationist or anaesthetist doesn't like Panadine Forte. I might give them ibuprofen, or in some cases they get endone. So good medication, post-op medication is important. Ice packing, so good post-op instructions so they know to ice pack, they know to take their painkillers as soon as they get home. Giving them your phone number is also very helpful, because sometimes I've had patients, I've finished the case, say 2 o'clock, and they ring at 6 o'clock and say, oh, do I start painkillers now? And I'm like, oh, you just call me earlier and I would have told you, that you reminded them, because sometimes they just don't listen to your post-op instructions. You know, take painkillers as soon as you get home before the anaesthetic wears off. So giving them access to you so that they can ask you questions is very important if you're doing surgery. Good post-op medication, and don't attempt any surgery that is going to take you 2 hours. It's too long. Half an hour, good. 45 minutes, good. An hour, okay. For a tooth, 4 teeth should be about an hour and a half maximum. Okay, so that's the best way I can think of to explain to you to reduce post-op pain is make sure your surgery is as neat and efficient as possible. Lots of irrigation so that you don't burn any bone. Everything is nicely irrigated. Don't munch your flap. It's not a very technical term, but nice, neat flaps so that you're lifting the periosteum right off the bone, because that periosteum is giving your bone blood supply when you close that back down with suturing. Neat suturing, not over suturing. That also will help. So I just use 2 sutures usually for each wisdom tooth site, and good post-op medications. We've got the second question was from Andrew. Would you do surgical draping if you are decoronating and sectioning a tooth but not raising a flap? The answer is no. I usually put a surgical drape on the dental cart because I like my instruments to be sitting on like a sterile cart rather than just like the dental bibs. So I'll have one drape on that cart with all my instruments on there, but I wouldn't drape the whole room or anything like that if we're just sectioning a tooth, no. Pretty much the only time you drape is if you're planning to raise a flap and you're planning to do a full surgical, and if you're sectioning a tooth, that's pretty much fine. But I like to have at least one drape for my, my dental cart, so my instruments are on that. We've got another question from Rohini. How high is the probability to hit the lingual artery or lingual nerve during mandibular molar extractions, especially when sectioning? What is your word of caution? Thank you again, smiley face. Thanks, Rohini. The probability of hitting your lingual nerve is not high if you don't go there. You really need to know your anatomy. So, for example, if we go back to that picture we had before, so if we go back to this picture and have a look, so say your lingual artery is, I think this is a maxilla, but it doesn't matter. Your lingual, go back. Your lingual artery comes round kind of in that position here. So when you're removing a tooth, if you stay buccal to that, then it's highly unlikely that you're going to hit it. I'll just show you, if go back to this case study here. Okay, so for example, say your lingual nerve is here, okay? If you do bone removal on this side and you pretty much stay away from anywhere past the long axis of that tooth, so anything lingual of this line, do not go there, okay? Then you're not going to hit your lingual artery, even if it's, you know, really, really buccal far here, you're not going to hit it. Where you're going to hit it is if you start drilling and you start drilling into this tiger country, then I can't help you, okay? You really have to know your anatomy, stay buccal, you know, remove bone from the mesial if you have to, remove bone from the buccal, section the tooth, you know, there's heaps and heaps of room here if you section the tooth, rather than go anywhere close to this tiger country. You know, I stay well away from this section here. Okay. Hope that answers your question. Write in again if I didn't answer your question. Suhei has another question. What approach do you take to remove bone level roots in the elderly, sometimes root treated? Really good question. I've got a referral recently. Patient is on Prolia for the past 3 years. And when I asked her, how long have you been on bisphosphonates for? They were on Actonil for 10 years before that. So it's Actonil for 10 years and then Prolia for 3 years. They're root canal treated molar teeth, and the referring dentist has asked me to remove the teeth. So in that case, I would actually talk to the patient and say, well, sometimes the best thing to do is to bury the roots and do a root burial. We may not necessarily remove all your teeth. It's not a huge issue to have some retained root. So for instance, if we go back to, just show you, if for instance we go to this case where we had a root canal treated tooth, this is a fairly straightforward tooth to remove, but say we had lots and lots of difficulty, we sectioned, we tried to get it out and it just fractured, just couldn't get it out, then what I'd do is get a round burr and I actually just basically bury the roots and drill it flat, okay, and then just bury the root there. If I'm able to, I actually get a straight burr and I cut the GP out of that root as well, okay? But you really need to know where you're going, okay, because your nerve is right here, okay? So if you don't know where you're going, I wouldn't recommend it. But for me, if I'm comfortable and I fractured a root and I can't get that root out and it's an elderly patient, I wouldn't necessarily make such a big effort to remove that small part of root. I would try as much as I can to either use a small round straight burr or a straight burr to remove the remaining root canal structure. So it's really easy to see because it's orange coloured in the middle of your retained root. So just buzz it and then remove it, leave the retained root, and you'll just get bone growing all the way over again. So anything, for example, if you have a retained root around about, say if it's not root canal treated, then if you have a retained root like so, that's not a big deal because it's below the alveolar crest. If you had a retained root, for example here, that's not going to work. You're going to get an infection. So you definitely have to have it below the alveolar crest so that you've got, say, 2-3 millimeters of bone, and that will basically grow over. When it's tricky is if it's root canal treated. I'd prefer to take that root out if it's root canal treated. But if it's down to the tip like this and I really can't get the rest of that out, I just basically drill the GP out and leave the retained root. I've got another question, I think. Keep them coming. From David Kerr. There seems to be conflicting advice about bisphosphonate and Prolia cases. I was taught clindamycin pre and post-op and to manage simple cases with less than 5 years of medication. Others say send all to specialists, and others again suggest post-op antibiotics only. What are your recommendations for general dentists? This is really interesting because you should watch this space. The current guidelines are clindamycin 5 days before, 300 milligrams QDS, 5-on-7. Don't forget the chlorhexidine mouth rinse as well for a week before, 3 times a day. The chlorhex is just as important as the clindamycin. And then after extracting the tooth, then 5 days after of the clindamycin, again 300 milligrams QDS 5-on-7, and the chlorhexidine mouth rinse again. This may be changing. The protocol, which is developed by New South Wales Health through mainly Westmead Oral Medicine Department, is changing. So they are actually thinking of possibly reducing that time frame so that the patient takes, for example, 3 days of clindamycin before the extraction and 2 days post-op. That change hasn't been put down in stone yet, so that it's kind of coming on the horizon, but it just shows that these are empirical guidelines. We haven't done like randomized controlled trials on this, so it's really empirical. And why the change is because 10 days of clindamycin is actually a very, very long dose, and there's a risk of diarrhea and Clostridium difficile and so forth. So there is something in the horizon where they may be revising this protocol. I often also just give amoxicillin 2 grams an hour before as a pre-op prophylaxis for Prolia or bisphosphonate patients, and then post-op I might give them the 5 days of clindamycin, so that way they're not having the 10 days, which is quite a long dose. In terms of whether a general dentist can do these cases or a specialist, it really depends on the extraction. So if it's a very, very difficult extraction to begin with, then you might consider referring. I've had Prolia patients refer to me with like mobile retained roots that are just in soft tissue. It's actually to do with the amount of trauma that you are going to do to the bone while you're extracting the tooth, and whether or not there's a problem with healing. Yes, it depends on the time frame that they're having the medication, but it also depends on your surgery. So if you feel that you can do the surgery well with minimal trauma, then I don't see any reason why you can't remove the tooth using that protocol. Do you have to do primary closure? Again, that was definitely the trend before, and the thinking now is also changing because raising a flap in itself is taking the blood supply off the periosteum, and then you've got to stretch the periosteum over to do primary closure. So now the thinking is also changing in the sense that we're not as proactive in recommending that you do primary closure for all bisphosphonate patients. So if it's a fairly straightforward, simple extraction, or even if it's, for example, a sectional removal that you feel quite comfortable with, that you can do, for example, a sectional removal within, say, half an hour-ish, so you know that you're confident in doing the best for your patient, and you can safely and atraumatically remove that tooth, then I don't see any reason why you shouldn't. It's just approach it like a normal extraction. However, if it's a very, very difficult, 4-rooted root canal treated tooth or something like that, then you really have to think twice and think, is there someone else that can remove this tooth better or faster or with less trauma, which will give the patient a better result? So that's up to you to make that judgment for yourself in terms of whether you would like to go ahead and treat that patient or not. So I hope that answers your question. Basically, look at the difficulty of the extraction, assess that, and then go from there. And also the patient understanding. If they understand that, if they do get bronch, it is out of our scope as general dentists to treat, and they would need to see an oral medicine specialist or an oral maxillofacial specialist. Then if they're accepting of that, then I think that is fine. You write everything down in the consent. You've offered them the different options, and they're aware of the risks. We've got a question from Naren Indukuri. Thank you for your questions. Keep them coming. Could I talk about upper 8 extractions with multiple roots if there is not much coronal tooth structure left? Good question. And from Sai Sathi Veresvaran, which material would you find best for improving clotting in a socket? I'll answer that one first because that's easy. Basically, anything is fine. Gelatamp, Surgicel, they all work. Spondrostan. So I don't think there's much difference between them. They will help if you have a patient that is on aspirin, warfarin, diabetic. So any of these patients, all of these materials help. And also a horizontal mattress suture. So you're actually using your suture to suture is like a hemostatic suture. So you're suturing to help A, leave the material in there, but B, also to help with clotting and hold the socket together. Now, that question about the upper wisdom teeth, let's see if we can find a case for you. If there is not much tooth structure left. So I don't know if I have a specific x-ray for you. Let's see if we can find one for you. Yeah, let's have a look at this one. For example, let's pretend that this tooth had caries. So there was, say, not much of the tooth left. Okay, if you're lucky, you'll still have some mesial. And I would then use a Warwick James. So Warwick James, which basically looks like a golf club. Okay, I'll pop that in and rotate. And if you rotate distal, you'll be able to rotate that tooth out. If it's the right side, using a right Warwick James, and again rotating clockwise, which is distal, again you can rotate upper wisdom teeth out when they have very, very little tooth structure. You can also use a luxator in this position and rotate as well. So with upper wisdom teeth, because the bone is soft, it doesn't matter so much if you have almost no coronal tooth structure, as long as you can get an instrument equicrestal or just subcrestal, round about this area, so that you've got a good application point with a Warwick James to rotate the tooth out, or a luxator. If you really can't see, then I'd do a flap. So my flap would be medial relieving incision, and then just along the gingiva. Raise the flap so you can see. If you have to, then remove some buccal bone, but very rarely do you really need to do that to remove an upper wisdom tooth. You really just need to get a good application point on the mesial there. So hope that answers your question. From Claire Shepherd, can you please confirm if I heard correctly that I prescribe dexamethasone 4 milligrams twice a day for 2 days after really difficult extractions? Yes, correct, I do. Sometimes the pharmacists will say, you're not a medical doctor, why are you prescribing dexamethasone? So I actually warn the patients when they go to the pharmacy and tell the pharmacist over the phone, look, it's for wisdom teeth, it's a short dose, it's only 2 days of steroids, you have to write 4 and circle 4 so that they only give the patient 4 tablets instead of giving them a bottle of 30, which is a problem. It remarkably reduces swelling. It's very good for post-op pain. It's very good for post-op swelling. So it's a really, really difficult extraction. You're expecting them to have pain and swelling. It does reduce post-op pain. If the patient is having IV, I ask the sedationist to give IV Dex. So it's a very good drug to reduce post-op pain. We have another question. From Carolyn Myhill, how would you approach extraction of ankylosed ease in an adult patient? That's a difficult one. So for ankylosed ease, I don't really have one to show you in terms of slides, but often, number one, I would tend to section the crown to be able, because sometimes they're actually, the 2 teeth either side are actually muscling that in, basically. So I tend to section it and then try and remove the crown. But I know that the ankylosed roots will actually stay inside. Often it fractures just subcrestal. So I actually get a round burr, the same technique that we were talking about for elderly patients and retained roots. I'll use a round burr and I will just remove the rest of the root as far as I can see, just by directly cutting the root, the ankylosed root out. So if I can see where the root is, then I'll use a round burr and just basically remove the root itself, leaving the bone around it. You really need to know how far to go, how deep to go. You don't want to go too deep. You want to be able to know in terms of the length of the root where you are. If you get stuck, take a PA and then you can see where you are. But it's not a big deal if you don't manage to get all of the retained roots out. As far as you can tell, if you just use the round burr and remove the roots that way, that's the method that I use. It's a difficult one. Another question from Sue He. For a tooth you didn't plan a surgical for, when do you decide that you need to raise a flap? Do you give yourself, say, 5 minutes, 10 minutes? What is your cutoff for extraction patients with high blood pressure? Oh, with BP. Okay, so there's 2 parts to that question. For a tooth that I didn't plan a surgical for, I would raise a flap when I get into a position where I can't see. So, for example, I'm sectioning a tooth, I'm doing well, I'm removing interseptal bone, and the roots come out fine. There's no need to raise a flap. However, if I've got, say, the palatal root comes out, distal root comes out, and I just can't see the mesial root, I'm not going to spend 30 minutes struggling because then I can't see. If I can't see, I'm going to raise a flap. So I would say if I can't see, it will take me 30 seconds. I'll just say I can't see. So we're going to get a scalpel and raise a flap, open, so we can see what we're doing. So I don't take too long to decide to raise a flap. That's because I've got all my instruments laid out there already. The longer you take to decide, the more time that you waste, but also the longer your surgery time, the more post-op pain, the longer your surgery time, the more swelling, the more it's not beneficial for your patients. So I think the answer to your question is, if you have difficulty with access and you feel you're struggling, don't struggle anymore, don't even wait 5 minutes, just raise a flap. And then you can see, you can access, you can, especially with mesial roots, you can remove bone a lot better if you can see what you're doing. From Jane Chubby, a non-bisphosphonate aged care patient had previous 3-1 exo with no issues, then quadrant 2 exo of 3 roots. Okay, 1 month's review has pus coming out from one of the non-patent sockets. Others have healed and bone exposed. Is it bronch? Would you advise debridement plus chlorhexidine, antibiotics or clindamycin, or refer straight away? If you feel comfortable, Jane, to manage the case, especially if it's non-bisphosphonate patient, then I don't see why you can't raise the flap, debride, see what you see inside, irrigate, close, and then monitor. If it gets to a point where, after doing that 2-3 weeks later, it's still not healed, even with antibiotics, and it gets to a point where you're worried that you can't manage it, then yes, always refer. So it depends again on your comfort level in managing something. If that patient had bisphosphonates, then you probably err on the side of referring earlier. But if the patient has just maybe some retained roots, or there's granulation tissue in there, it's not healing well, then they could heal quite nicely with some antibiotics, raise a flap, curettage all that granulation tissue out, close, and just review in a couple of weeks. So it depends on what you're comfortable with. It's always nicer to refer early. So if you're going to refer something, refer early instead of trying and then refer. But if you're confident in managing something, there's no reason why you can't. So there's no right or wrong answer for that. Yeah. How do you minimize the risk of fracture of maxillary tuberosity? Really good question. When extracting upper wisdom teeth, what post-op measures should you take or advise patient to do if there is a fracture of a tuberosity? So your planning is really important, Chen. Most of the time, these maxillary tuberosity fractures in male patients where the bone is quite dense, and you're using a luxator with too much horizontal drive. So you're actually putting a luxator in and twisting, and you put too much force. And with that force, basically the whole tuberosity will fracture, because the thinnest part is that, if we go back to the slides, say for example, in this case, if you put your luxator here and just put so much force distal, you're going to fracture the tuberosity. So if you're in a position where you put the luxator on, you try, and there's no movement, even if it looks like a simple extraction like this, I would stop there. I'd actually raise a flap, and I'd start removing buccal bone to reduce the amount of force that you're putting on to remove the tooth, and then some distal bone as well. And then you've got less force distally when you're removing that wisdom teeth. It's very common with older and male patients, and also you have to look at their build. So the tooth might look very, very simple to take out, but you have to look at the bigger picture, what the patient looks like in themselves. If they're like a 6-foot guy, basketballer, and the wisdom teeth look like this, it may still be difficult. If you put a luxator on that and push too far distally with rotation, this whole section will fracture. Okay, and what to do? It depends. I've been called out several times when, say, a colleague next door has fractured a tuberosity. I would assess the situation. Sometimes you actually just push the tooth back and call it a day. You can splint it to the next door tooth and let that heal. And if it's quite a big fracture, and refer. Don't keep on going. If you feel that you can manage the situation, and you want to remove the tooth without taking out most of the tuberosity, I'll actually peel the periosteum palatally and buccally off the tooth so that you can remove the tooth with the buccal bone, hopefully with not too much palatal bone and not too much distal bone, and you still have that soft tissue that you can then close with. So you've got to have quite a lot of experience, I think, to deal with something like that. But basically, if you fractured tuberosity, you've got to assess how much have you fractured. If it's small, it's fine. If it's a bit of buccal bone, it's fine. But if it goes all the way up to pterygoid fossa, then I think you start to get worried, and it's better actually just to suture it up and refer. Don't pull the tooth out, because if you pull the tooth out, you will take all that soft tissue out with it. Massive bleeding, you can't manage it, and it's a bit of a nightmare situation. So if you do fracture a tuberosity and you assess it and you feel that it is very, very high up, I would just close up, suture, maybe get some composite and wire, splint it, and then refer off at that point. But I myself, if there's a fracture, I would actually basically peel the soft tissue off that fractured section, remove the tooth with whatever bone is fractured, and then use that soft tissue to close the wound. Then I would give the patient antibiotics, dexamethasone, painkillers, and some Otrivine or Nasonex spray to manage. So again, I think you really have to, it's like in a similar situation where it's up to you whether you feel like you can manage it or not. If you can manage it, go ahead. But if you can't manage it, then refer. And don't continue to pull that tooth out. Just close it up, stitch it, try and get that tuberosity to be stabilised if it's splinting or suturing or whatnot, and then send the patient off to be managed if you're not comfortable. From Raymond, in wisdom teeth extractions, does swelling decrease if the flap does not achieve primary closure? I think there's so many different factors in terms of swelling. So if you do or do not close primary closure, I don't think it really impacts upon the swelling. If I raise a flap, then I'll do primary closure. But I suture only 2, sometimes 3 sutures. So it's not tight. It's just for clotting and to prevent food getting trapped. If it's a simple luxator extraction, I don't raise a flap just to get primary closure. I just leave it. If maybe do a hemorrhagic suture if you want to, but often no. If you don't raise a flap and you just luxate the tooth out, there's no need to suture, no need to achieve primary closure. Another question I think we have. From Sandia, what approach to take when extracting firm molars with buccal and palatal tori? If there is a firm molar with buccal and palatal tori, you really have to take a surgical approach, and I would be looking into removing guttering, basically. You don't have to remove all of the buccal bone, but you have to gutter so that you're freeing up the tooth from the socket plus section. So you're not going to be able to luxate and put a force upon the tooth and remove it from a contemporary extraction point of view, a traditional extraction point of view. You need to plan a surgical, because that tooth will not move unless you A, section, and B, gutter the buccal area, because you don't have any give in the bone on the buccal. So in answer to your question, planned surgical removal in that case with buccal bone guttering and sectioning. From Suhi, following up from past question about a blood pressure cutoff for exo patients. I don't feel like they're, well, maybe 200, or I think it's more what the patient looks like clinically. So if they look short of breath or they don't look clinically well, then generally speaking, I wouldn't take the tooth out because the tooth is elective. So yeah, I wouldn't really put a number on it. So sometimes people walk in, they've got, 160 or 180, but it's like a simple extraction. They're on blood pressure medications. If you keep them nice and comfortable, then you can remove the tooth. But I think it's a little bit of a difficult question to answer. It depends if they're having an emergency or not. So if they're in pain, their blood pressure could be up as well. So if you can relieve them of that emergency situation, then they're better managed. If you're really worried, then just send them back to the GP. Tell the GP to review their medication, review their management, just give them antibiotics until you can get that blood pressure monitored better, a little bit better managed, and then rebook. Usually teeth removal is not urgent, it's usually elective. So I would decide on the basis of the patient's presentation. Is the tooth that important to remove today, or can you send them back to the GP to review their medication and management and then bring them back and do the surgery another time? Or are they in so much pain that that's the cause of their blood pressure being high? Then if you're able to, then manage the extraction. From Carolyn Myhill, do you suture after simple extractions if placing an immediate denture? No, I don't tend to. Unless they have bleeding problems, like say they're on aspirin or warfarin, then I'll suture. Most of the time, no, if it's simple extraction. Yeah. Another question? From Paul, do you use high-speed surgical handpieces at all? High-speed surgical hand. Do you mean, Paul, do you mean like dental high-speed surgical handpieces? If that's the question, then no. I always use a one-to-one surgical motor with saline irrigation. I think it's a real struggle, I think, to do surgery with a high-speed handpiece. Number one, you don't get enough torque. Number two, the head of the drill gets in the way, so you can't section teeth, you can't get down into furcation. It's just not, it's the wrong tool, so it's not ideal at all. No, yeah, I always use a surgical handpiece. I think that's part of, being efficient surgery, you need the right tools. From David Lin, how do I take caution when raising a flap or drilling away buccal bone when I'm extracting a lower premolar that is close to the mental nerve? So if you're raising a flap close to the premolar, I would do an envelope flap. So for example, say for instance we're taking out, for no apparent reason, say we're taking out this 3, 4, okay? If you had to raise a flap, so say it was carious right down and there was no tooth structure left, just the root, and then we've got our nerve here, I would raise an envelope flap, and you can't go wrong if you raise an envelope flap. Just don't do a mesial relieving incision and you'll be safe, okay? And if you have to, then do a distal relieving incision, yeah? When you're removing bone, just remove bone up to about halfway down the root. Don't go any further. Yeah, so sometimes your nerve will come out somewhere along this kind of position, okay, a lot higher than what you see here. So make sure that you don't go any further than your tooth. Remove buccal bone is fine. Remove interseptal bone is fine. Just don't keep going down and down and down along the root, especially in this case, if it's the 4, then don't start drilling distal. If it's the 5, don't start drilling mesial. So it's just about knowing your anatomy, where to avoid. So for example, if you're taking the 5 out, you would take distal bone out, take buccal bone out, but try not to go too deep on the mesial, because you know somewhere in here is your nerve. So take out more bone on the distal, take out buccal bone, raise your flap so you can see what you're doing, and go from there. But just knowing where you are, I think, is the most important thing. We've got about 15 minutes. Are you interested in CT scans, or do you want to do more questions? Are there any more questions coming over? I can do your question. One last question. From Kathleen. Do you have any specific tips in managing patients on medications such as apixaban, etc., tranexamic acid? Yes, so I just had a patient today on medications that thin blood, so example, apixaban. I do basically normal extraction procedure, then I'll put gel foam in, I'll do a hemorrhagic suture. I'll get the patient to go to a compounding pharmacist and get a script for 5% tranexamic acid. And I'll teach them how to pour that onto a piece of gauze and then bite down on the gauze for 5-10 minutes after surgery. Keep them in the surgery for 5, 10, 15, half an hour if you can, to monitor, and tell them to keep doing that at home afterwards. Review in a couple of days' time if you can, and make sure they're doing okay. Generally speaking, I don't stop their anticoagulants. That's the current protocol. However, sometimes the GPs are happy to, so if they're happy to, that's fine. I would call the GP and talk to the GP and see what they're comfortable with. But most of the time, we don't stop their anticoagulants. Then 5% tranexamic acid, topical, post-op, on the gauze, in pressure bandage. Okay, and review, that's really important. So we'll spend the next 10 minutes on CT scans. So some people wanted to know when you need a CT scan and how to read it. So previous. Sorry, just gotta find the start to this. Okay, so you could probably go into this into more depth yourself, but when you see an OPG with darkening of the roots, deflection, narrowing, bifid apex, all of these situations call for a CT scan if you're doing a wisdom tooth removal. So for instance, here the roots are darkened because they're crossing your nerve. There's a deflection of the root in this case. There's a narrowing of the root. So for example, I'll show you another one. So reading CT scans, basically you need to know this is axial, this is coronal, and this is sagittal. Okay, so remember that because we'll get back to that. So we used this case study before to have a look at the 4/8 and the 3/8. So in this instance, if we look at the 4/8, there's a number at the bottom here. So for example, this number here is 50, this number is 40, and that corresponds to the number on your sagittal or axial view, okay? That then also corresponds to your axial view here with these numbers. The important thing is actually that this slice is your panoramic curve, and that panoramic curve has to be mapped so it corresponds to your arch. Why? Is because if, for example, that curve was somewhere out here and we took a slice this way, then you're not going to get a slice parallel to your jaw, okay? So we need this slice basically straight up and down, but also it has to be 90 degrees to the parabola of your arch, okay? So for instance, in this situation, we're looking at starting, say, look from this end, from the mesial to the distal. So from mesial would be 53, 52, 51. So we're looking from mesial backwards, and you can see how the nerve gets closer and closer. Sorry, the nerve here, here gets closer and closer to the two root tips. So right in that situation there. So in this particular situation, we want to look at the 4-8. So we're looking at somewhere between, say, 40 and 50, and we want to look at the nerve and how that relationship is with the roots there. So between 40, sorry, it's 30 and 40. Go back. 30 and 40, again, we've got our tooth and our nerve, tooth, nerve, tooth, nerve. And as we go back, we can see that the nerve here is very close to the root. Oh, I'm going backwards, I think. So last case, and I will flip to my computer, so it's a little bit easy to explain, I think, on the computer. Oh, sorry, I'm going to give up on this one, I think. Okay, we're going to switch. 1 second. I'm going to switch to my laptop. Okay, I think this is a much better way to explain. So this is co-diagnostic software. Basically, I asked for a DICOM view, DICOM CD, and it comes back and I enter it into my software. And I'm able to see this is a panoramic view, okay? And you can see I've traced the nerve here before. And this here is my cross-sectional view. And you can see the nerve here. And as I scroll, it's going mesial. And as I scroll backwards, it's going distal, okay? And if you look at the axial view, if I scroll, this is the bottom of the mandible. As then I scroll up, you can see the mental foramen here, and the genial tubercle. And as we keep going up, sorry, other way, we come to the lower teeth. And your wisdom teeth, you can see the nerve lying distal and lingual to the 4-8. When you're looking at this axial view, just remember you're looking at the scan as if the patient's lying on the table with their feet towards you. Therefore, this is the right-hand side and this is your left-hand side. So just remember that it's like you're standing at the foot of the patient's bed. So they're lying down, head towards the wall, you're standing at the foot of their bed, and this axial view for all CT scans are always going to be right on this side, as if you're looking from their toes up, and left is on this side, so that you don't get confused. Always remember that, so that you know from an axial point of view what the orientation is. Okay, so if we go from the axial view back to the cross-sectional view, okay. Then we start from, for example, the distal. Here we go. Inferior alveolar nerve is here, and you can keep tracing, and there we start seeing the 4-8 with the nerve there. So it is underneath, so it's inferior and goes slightly lingual. Lingual is good. If it's buccal, it's very, very difficult because we access wisdom teeth from the buccal. If we go to the other side, we can look at this side here. So then again, if we look at all the different views, orientate ourselves, 3D view would be, say we wanted to see this 3.7 here. So from an axial point of view, we can go from underneath the mandible, looking up, and we can start seeing our tooth here. And from an axial point of view here, sorry. So we're going to trace, for example, here, that's your mental foramen coming through and then coming all the way backwards. And that's the ramus. Ramus, inferior alveolar nerve, and there's our 3.7 tooth. And there is here your mental foramen. I hope that gives you an idea. It's kind of more difficult than I thought to show you how to read a CT scan. But basically, the views that you need to understand are how the axial view matches with your sagittal view, and to appreciate that when you look up and down, like so, this panoramic curve has to match your arch. And then this view from this side matches this cross-sectional view. And basically, if you play around enough, you can start tracing your nerves and tracing where that nerve goes in relationship to your teeth. And you can trace your mental foramen, so forth, forwards and backwards. I hope that helps. It's a little bit difficult to show you how to read the CT scan, but if I move this up and down, then you can see the relationship of the nerve to the tooth in 3D. Okay, I'll go back to any questions on, one last question. How does knowing the proximity of the inferior alveolar nerve to the root change your approach to extracting? It changes my approach a lot. Number one, maybe I'll just decide not to remove the tooth at all and refer it off if, for example, in one of the cases I showed you, the nerve is between the two roots and the patient is not accepting of the risk of nerve numbness. So I can actually show the patient this scan, show them, look, this is where your nerve is. Your nerve is between your two roots. It's very, very highly likely that A, we've got to bury the roots, or B, you'll have nerve numbness. Is that something that you can accept? And if you show them the scan that they can't accept that, then either don't do the surgery if they're not symptomatic, or refer the patient off. So number one, that CT scan actually helps me decide in terms of case selection if I'm going to do this surgery or not. B, if I know where I am anatomically, so I know, for example, the nerve is lingual, then I know that I'm pretty safe to keep removing bone on the buccal to access my tooth and to section. But if I know that inferior alveolar nerve is buccal, then I would be very, very wary of removing buccal bone. So my approach would be more a sectional removal. I might remove a little bit of buccal bone, but not too far down, because I know if I luxate or drill any further buccal, I'm going to hit the nerve. So that scan is basically your map. Like, without that map, you don't know where you are. So if it's a wisdom tooth that's not close to the nerve, it's not such a big problem. But a lot of the cases I do are close, so I need that scan to show me exactly how the nerve traces through and where it is in relation to shipped to my tooth, so that I can plan my surgery to avoid the nerve. So usually it ends up being sectioning the tooth rather than taking buccal bone away. And it's also for my peace of mind if I know where the nerve is. It's on the lingual, that's fine. I'm able to stay away from that. And thirdly, the same point about patient information, patient consent, so that they know where the nerve is. You've shown them, they understand the risks, and then you're going ahead with your own knowledge of where the nerve is, and the patient also knows where the nerve is. This is very important for medical legal reasons, also for the patient's consent in terms of understanding the risks, and for you as well. You might look at the scan and go, oh, that's I'm not comfortable with that. Let's refer that off. If you didn't have the scan, it might not look as bad as you thought if you didn't ask for a CT scan. Okay, thank you for all your questions. Hope it makes the webinar very interactive, and a bit more discussion is really good. Thanks for joining in, and have a good night.